Well, greetings, everybody. My name is Professor Bob Mash. I am based at Family Medicine and Primary Care at Stellenbosch University in South Africa. And this is just a brief contribution to the virtual AfroPHC workshop on the theme of building teamwork for primary healthcare in Africa. So in addition to being based at Stellenbosch University, I'm also currently coordinating the Primafamed network, which stands for Primary Care and Family Medicine Network in Sub-Saharan Africa, which is a network of departments of family medicine and primary care, which I think currently we have around 40 institutions, 40 departments from about 25 countries in the region. And we're also working closely with sort of the academic wing of Wonka Africa. So as a sort of conceptual framework for primary healthcare to kind of maybe guide what I'm going to say, I've put up here the Primary Healthcare Performance Initiative conceptual framework, and you can see that what they've tried to do is to identify all of the essential ingredients of effective primary healthcare. And they've put them up as something of a logic model. In the left, you can see the column on the system, which is a high-level systematic policy-related factors. And then the inputs that are needed, the second column, the green column, into the service delivery, which is the middle, often forgotten about box in the gray in the center of this picture. And then the outputs that relate to effective service coverage for all the different conditions and burden of disease. And then finally the outcomes relating, of course, to the health status of the population, to the equity of primary health care, and so on. So in relationship to this discussion, which is about the primary health care team, certain parts of this framework are particularly relevant. So, of course, in terms of inputs, it's the workforce and who is in that workforce for the primary health care team, what type of health professionals do we need, how many do we need, and how are they trained, and so on. That then can follow through to the piece there under facility organization and management on team-based or collaborative practice organization, and then following through to the availability of effective primary healthcare services. And there you can see it talks to the fact that the members of the primary healthcare team not only need to be available, but they also need to be competent and motivated and to practice safely. And then the final piece of this chain is that all of this eventually contributes to high quality primary health care, which is characterized by being accessible, by providing ongoing care, both informational and relational, by being comprehensive across the life cycle, across the burden of disease, and from health promotion to rehabilitation and palliation, by being both coordinated, parallel coordination and sequential coordination, and maybe most importantly, also being person-centered. So that I just want to keep this framework in mind as we address these three questions that Sabir has given us. So who are we? What does the community want? And then who should be part of the primary healthcare team? So in answering this first question, who are we, in this talk, I'm sort of taking the standpoint of, I suppose, family medicine and more the kind of the doctor in the team. And this picture shows how we're currently conceptualizing the role of the family physician. The family physician being a doctor with postgraduate training to become a specialist in family medicine. So you can see that there are three key areas. The one is that this person should be a clinician. They obviously should be a competent clinician and a consultant who can advise and assist others in the primary healthcare team. You can see that there is a role around being a capacity builder and a clinical trainer. Obviously, this person has had a lot of training and time and resources invested in their development as a health professional, and part of their role is to build the capacity of the rest of the team, often people with less training and sometimes experience, thinking of junior doctors, of nurse practitioners, of community health workers, and sometimes also in relationship to formal students as a clinical trainer. And then lastly, and a very important role in what we've referred to as clinical governance, but which in essence means taking responsibility for improving the quality of clinical care and patient safety along with the team. So where does this person sort of deploy these roles, as it were? And I put here that it's across actually 3 different contexts within the district health system. So at the left-hand side, in a lot of countries, the family physician is being deployed at the district or primary hospital, doing outreach into their primary care or primary healthcare platform. In many contexts, the family physician is actually full-time at the primary care facility. And in many cases is also working in the community with community health workers and other health workers. So the family physician may exert those 3 broad roles at the level of the district hospital, the primary care facility, or the community, and sometimes a combination of all of these. And just to sort of some pictures of the roles. So here is one of our newly qualified family physicians working in South Africa, I think actually from Ethiopia originally, here in primary care, here in the district hospital, here in the district hospital involved in antibiotic stewardship, an aspect of clinical governance, and here on the right-hand side involved as a capacity builder, training the rest of the healthcare team here on obstetric emergencies. So in a way, the family physician, in terms of sort of the doctors, is at the sort of upper end or final end of this pipeline of training. And in our region, there are still very few specialists in family medicine or family physicians. And of course, there are a lot more medical officers and general practitioners. And while some of them may decide to take up opportunities to train as family physicians, we also need to be providing training for this group. And often in South Africa, for example, that is now being offered through a 2-year diploma in family medicine. And then at the far end, coming into the profession, are the interns, and in some countries, community service doctors, the junior doctors, who may or may not decide to join this pipeline towards becoming a family physician. So the state of production, as it were, of family physicians in sub-Saharan Africa varies a lot between countries, and we've actually used this stages of change model to try and identify where different countries are at. You can see that in terms of a sort of a permanent commitment to family medicine training, countries like Ghana, Nigeria, and South Africa seem to be in a sort of permanent state. A number of countries are at maintenance. They've set up programs. Those programs are now delivering, but still, to some extent, consolidating their place in the health system. As we put here Botswana, Uganda, Lesotho, Kenya. There are countries that are taking action, that are implementing training. Maybe they haven't yet had many graduates or very few graduates. Zimbabwe, for example, has just started training this year. Malawi is just producing its first graduates, and so on. Then there are those countries that are contemplating family medicine training but do not yet have it, and then there are those that are not even thinking about it. So there's quite a variety in terms of where countries are at in the training specifically of family physicians. So coming to this question of what does the community want, and I added, and what do they get, this is an example of a tool that can be used to evaluate these key elements of primary healthcare that we know are linked to high quality and to the delivery of effective primary healthcare for communities. And this is using what's called the primary care assessment tool, and the tool has three components, and I'm going to focus here on the component that the patients or the people, community members, fill out to give their feedback on the quality of primary healthcare. There are also tools for managers, which is the sort of grayer solid line, and for healthcare providers, which is the dashed line. But the solid darker line is from the patients. And in this spider diagram, you can see how patients viewed the quality of primary healthcare in South Africa. And you can see here, for example, that they rated coordination fairly highly, or at least compared to some of the other components. And what this percentage is here from 0 to 100 is the percentage of patients who scored that item 3 or more. And that means that they felt that that was going pretty well for them in terms of their primary health care. So around 70% felt coordination was going pretty well, and a similar amount, around 70%, felt that services were fairly comprehensive and were also culturally competent, and that most of the team members were present. However, much weaker areas for the patients were first contact accessibility, how easy it was to access care when they needed it. The community orientation was low as well from their perspective, and then some of the other items were sort of in between. The other interesting thing that this primary care assessment tool shows us is where the viewpoint of the patient, what the community wants, what they think they're getting, and the view of the manager and the providers differ substantially. So you can see for comprehensiveness and coordination, they're actually pretty close in their viewpoint. But in terms of first contact access, patients feel things are much less accessible than the managers and providers, where there's a big difference in opinion. Similarly, with community orientation, the managers seem to think they're doing exceptionally well, whereas the patients feel they're doing really quite poorly. So this gives us, this tool is very helpful in giving us a sense of the strengths and the weaknesses of the quality of primary health care. And currently South Africa has adapted this tool, Malawi also, and Kenya and Uganda, I think, are busy with adapting this tool to their own contexts. So who should be part of the primary healthcare team? And I've sort of already alluded to this, I suppose. This is a conceptual framework that came from Ethiopia. So they said, okay, it should be family physicians, health officers, midwives, nurses, community pharmacists, social workers, and health promoters. That was what they saw as the team based in their primary care center. There are three issues that I thought I would want to just dwell on here. The one is that I feel that the team has to include both the people in the facility and the community. So in a sort of community-orientated primary care approach, the team should include also the community-based team members, such as community health workers and others, such as nurses who might be actually working in the community and not in the primary care facility. Then, of course, you do also have the sense of a core and extended team, a core team who are directly consulting patients, and then an extended team who are required to offer additional services where needed. And often that might be people who actually visit the facility or visit the area as opposed to being permanently based there. And this might include, allied health providers, various, like dietitians, physiotherapists, occupational therapists, and so on, as well as more administrative, managerial, reception staff. And I'm glad to see that Ethiopia had both the sort of the health and the social service component in their team, and I think both are essential in the primary healthcare space. So the other issue that this raises is, what can a country afford in terms of coverage, and what is possible to ensure that the team delivers on high quality. So I know in South Africa, for example, when we entered into our democracy in 1994, the policymakers in essence felt that primary care needed to be nurse-led, because that was the only way in which coverage for the entire population could be provided within a reasonable time frame. Nurse practitioners, however, are trained for 1 year part-time, and to expect them after 1 year of training to take on the whole of primary care and to provide quality care is quite a tall order. And that's why then the quality issue then comes into play. So given the restraints of the system, the ability to afford different types of healthcare workers and their availability, how can one ensure that the primary care team does actually provide quality? And I think this is, for me, where the concept of having a family physician or a doctor, hopefully with postgraduate training in family medicine, as a part of the team becomes very important. So not that the family physician or primary care doctor would provide all of first contact care, but would take the role more of a consultant to the primary care team, bringing additional expertise into the community, into the primary care level, supporting the team, building capacity, working with the team on improving the quality of what is happening, so that you combine in the team the ability to cover and provide access, while at the same time to build quality and patient safety. So what is needed to support the team? Clearly, from a high level, from a national, provincial level, state level, there is a need for commitment to primary health care. And different countries, I think, have different levels of political commitment, and that political commitment translates into different levels of financing for the health system as a whole, and also within that for primary health care. And although all governments have signed up to the Astana Declaration, I'm not sure that is always translating into action. Of course, all those inputs that I showed you earlier on, those are all needed for effective service delivery, and becomes the responsibility of the state or province or district to ensure that those are available. And as I mentioned previously, of course, the workforce, the nurses, the community health workers, the doctors, and others must not just be available, but must be competent and motivated. And there are all kinds of factors that are affecting their motivation, as well as the training affecting their competence. And of course, one could add to that also they should be equitably distributed. And this requires, of course, alignment of the health and educational systems. In the health system, there needs to be a human resources for health policy that clearly prioritizes primary health care and tells us what sort of supply of team members are needed. And the educational system needs to align with that to actually provide that at scale. So, for example, in South Africa, we've just analyzed our human resources in terms of family medicine and concluded, in fact, that the educational system needs to triple its output if we are to meet our basic needs within the next 10 years. Then, of course, the problem exists that these team members are often trained in isolation of each other by different disciplines and with different sets of assumptions, even values. And I think that there is a need for us to come together to recognize what we have in common in a sense as generalists, and to train around a core group of values and principles for primary health care that also enables people to enter into collaborative practice with each other. Another key issue, of course, is effective leadership and management at the low level, effective supportive supervision of the primary healthcare team. And this, I know in South Africa and in many countries, is a major problem, that we don't have effective leadership and management at the district and lower levels. Clearly, of course, we need health information at the facility level to guide practice, and to identify what the local healthcare needs are. And given our absence of electronic data and big data, and the way in which our health information systems tend to centralize information rather than distribute information or even analyze the data, remains a problem for many. And then finally, of course, what we also need is feedback on performance, and we need comprehensive and integrated performance management systems. So not just a few ad hoc audits of different things, but some sort of systematic approach to measuring and giving feedback on performance. So that is the end of what I had to say. I've hopefully answered some of that in terms of who are family physicians and family doctors with family medicine training, what the community is getting or needing in terms of quality primary health care and how we can measure that. And then finally, a little bit on what the essential membership, as it were, of the primary health care team might look like, and the support needed for that team. Thank you very much.